now get to introduce our first speaker, Dr. Ashish Patel. Dr. Patel is the Division Chief of GI here at Phoenix Children's Hospital. He came to Phoenix from the University of Texas Southwestern Medical Center in 2020, last year. At UT Southwestern, he was the Associate Clinical Director of their Pediatric GI program since 2019. He also served as the Director of the Southwestern Pediatric Inflammatory Bowel Disease Center at Children's Medical Center in Dallas since 2010. Dr. Patel completed residency at Texas A&M Health Sciences Center, Scott and White Hospital, and he completed his fellowship in pediatric GI at UT Southwestern Center in Dallas. He has served on numerous local and national committees during his time at UT Southwestern, including the Crohn's and Colitis Foundation of America Leadership Council, the UT Southwestern Faculty Senate, the GI Patient Education Physician Champion, and numerous residency education and research committees. In addition, Dr. Patel has been actively involved in clinical, industry-sponsored, and NIH-funded research in inflammatory bowel disease. Dr. Patel has a successful track record of publication with more than 50 original research publications, clinical guidelines, and case reports. We're sure glad he's here at Phoenix Children's in our GI division. He's going to speak to us this morning on the evolution of pediatric IBD. Dr. Patel.
Thank you, Micah. Thank you for the organizers of the conference, and thanks for having me. It's a pleasure to be here. I too second the idea that we need to do this in person. I was looking forward to this conference to actually meet many of you here in the community, as well as many of you that come from all over the country for this great conference, and hopefully we'll be able to do that next year. So I'm going to talk today about the evolution of pediatric inflammatory bowel disease, which has been a real passion of mine in the treatment of pediatric IBD throughout my career since I finished fellowship there in Dallas. So a quick disclosure, I'm a consultant speaker for AbbVie, and like Micah said, I am absolutely happy to answer any questions. So please, as we're going through this, please feel free to put the questions in the chat, so hopefully we can get to them at the end. So our goals today for the conference is to review the current understanding of pediatric inflammatory bowel disease, discuss the current therapeutic options in the treatment and management of IBD, understand the risk of immunomodulation in pediatric IBD, and I think that's particularly impactful to the general pediatrician as well as the subspecialists that interact with these patients across the spectrum, and then monitoring, surveillance, and immunizations in your IBD patient, which again is impactful to all of those groups. So as we know, pediatric inflammatory bowel disease is a chronic, relapsing, and remitting disease characterized by inflammation, ulceration, and bleeding in the GI tract. It's a systemic disease with the primary site of involvement being the GI tract, and it includes the spectrum of Crohn's disease, ulcerative colitis, and what we now refer to as IBD unclassified, or IBD-U, formerly referred to as indeterminate colitis. IBD can present with significant phenotypic and genotypic variability, and we'll talk a little bit about that. I thought here at the beginning I'd give an example of an IBD patient, but as I started thinking through that and wanting to really share what we see, actually what I wanted to emphasize is how diverse the IBD patient could present to you as. So I have actually several cases of different patients that I've seen over the years. Here, 12-year-old Caucasian male comes to your office, 6-week history of increased diarrhea, stools, no overt evidence of bleeding, but heme positive in your office, complains of a 7 to 8 pound weight loss. During that time, complains of right lower quadrant tenderness and low-grade fever, has a family history of a mom with Crohn's disease. His ethnicity is Jewish. This is actually probably what you remember from the textbooks. Very common description in the Caucasian patient, Jewish ethnicity, occult bleeding. But what else do we see? How about this child? 15-year-old African-American male presents to your office with a 4-week history of bright red blood per rectum going 8 to 10 times a day. He appears pale. CBC reveals a hemoglobin of 5, platelets of 750, and a white blood cell count of 18. So thrombocytosis, leukocytosis, and a severe anemia. Patient has tenderness in the left lower and upper quadrant, so basically all over, and no significant weight loss or growth failure, and no family history. They actually used to say that African Americans cannot get inflammatory bowel disease, and we know that is the farthest from the truth. And in fact, we were involved in a large study called Genesis that's continuing to collect information on African-American pediatric IBD patients. And we're looking at both the genotype and the phenotype in that patient population. How about this child? 6-year-old Asian American female with 4 to 5 month history of joint pain. On further questioning, associated vague abdominal cramping and foul smelling flatulence. Joint pain is typically located to a single joint. Complains of knee swelling and ankle swelling with pain on movement. Rectal exam reveals a heme-positive stool and multiple perianal tags. So on the surface, didn't come to you for GI symptoms, but came to you for joint complaints. And this is a younger kid, but then on examination, reveals some GI symptoms. And we've seen this similar patient that really presents with no GI symptoms and is brought to our attention because of the astute pediatrician recognizing that the symptoms may be a constellation that may represent inflammatory bowel disease. And similarly here, this is often a consult that we get from our pediatrician or our endocrinology partners. 14-year-old Caucasian female presents with just growth failure. Growth and weight are well below the 3rd percentile. Sexual development is Tanner 1 with no evidence of menarche. Patient has recently developed these raised, exquisitively tender lesions on the extensive surfaces of her legs, and the dermatologist diagnosed her with erythema nodosum. So what I tried to do there in these cases is really highlight for you the significant clinical variability that you can see in patients with pediatric inflammatory bowel disease. The clinical variability is highly dependent on the involved location of disease. So for instance, patients with small bowel disease are more likely to present with occult bleeding and growth failure or weight loss. On the other hand, large bowel disease patients often present with those bright red bleeding, severe anemia, and often is less likely to be associated with growth failure or weight loss. And let's remember now that the diagnosis of inflammatory bowel disease does not discriminate by age, sex, or ethnicity, though there can be higher risk groups that we have seen all groups of patients being diagnosed with this disease. And we'll talk a little bit about age too. The textbooks say, well, adults get inflammatory bowel disease, 2nd and 3rd decade of life, and 4th and 5th decade of life. Here at PCH, we take care of about 450 pediatric IBD patients, and we see lots of those patients present before the age of 10, early onset IBD, and below the age of 6, very early onset IBD. I like to throw this old textbook description of the comparison between Crohn's disease and ulcerative colitis on the slide deck, maybe to jar your memory or give you PTSD from medical school, but it just gives you that sort of nice comparison of the different features of Crohn's disease versus ulcerative colitis. Remember that one of the main things that define it is real estate. So Crohn's disease can affect anywhere from the mouth to the anus, and ulcerative colitis should really be localized to the large intestine. When I'm teaching fellows and residents and medical students, the other thing I try to impress on them is the depth of inflammation, and that will help you then remember what other complications can occur. So remember, Crohn's disease is a transmural disease, and therefore can be more associated with things like stricturing and fistulizing disease, whereas ulcerative colitis is a submucosal disease, and that's why you get a lot of that acute bleeding and ulceration, because it really affects the top layer of the large intestine. Remember, with Crohn's disease, there is no cure. It's a lifelong disease without a cure. With ulcerative colitis, it is a lifelong disease, but a total colectomy in those patients can be curative. So here's what I was talking about with ulcerative colitis versus Crohn's disease, at least in terms of the location and sort of that layer of involvement. And you can see, hopefully you can see here in this ulcerative colitis, it affects only the inner layer of the bowel wall, whereas in Crohn's disease, it may affect all layers of the bowel wall. So where does Crohn's disease, where does the name and the history? I always like to talk a little medical history in the talks. It gives us a little bit of perspective. You know, we often think of, we think now the time we're practicing in now, we know everything. And Still, it's a discussion we have with parents. We don't know. We don't know a lot of things as it relates to inflammatory bowel disease. For example, we don't know what causes inflammatory bowel disease. We don't have a, quote, smoking gun in terms of the etiology of inflammatory bowel disease. But Crohn's disease, or Crohn's, was first described by Dr. Burl Bernard Crohn, a Jewish American gastroenterologist that was at Mount Sinai in New York City, when he published a case of 14 adults that had terminal ileitis that became known as Crohn's disease. I've heard a lot of varying stories about this legend, and the most common one I hear is that actually Crohn's was not the one that was intimately involved in this study. It just happened at the time in 1932 that the authors were listed in alphabetical order. So his name appeared first, and this became known as Crohn's. I believe it was actually Dr. Ginsburg that had a key role in a lot of this description. So it's an interesting historical perspective. So let's talk about epidemiology. Who does this affect? Where does it affect patients? We know that there tends to be a north-south gradient, that it seems to be more common, more prevalent in the northern hemispheres versus the southern hemispheres. Is that because a lot of the developed countries are in the northern hemisphere? Possibly. And a lot of the second and third world countries are in the southern hemisphere. The male to female ratio, if you look worldwide, adult and pediatrics, it's pretty equal. And like I said, 2 peak diagnoses, the second and third decade of life and the 5th and 6th decade of life. We know that there can be some genetic and ethnic underlyings of this disease. It's thought that if you have a first degree relative with inflammatory bowel disease, that your relative risk, the child's relative risk of developing inflammatory bowel disease is 15 times that of the general population. And that's why that's one of the key questions we always ask and gather a very detailed family history in these patients. And I extend that outside of just IBD. I really try to dig into any other autoimmune history that these patients may have. We know that there's a higher prevalence in the Jewish population, regardless of geographic location. For example, the Jewish population that lives in Mexico City has a higher incidence of inflammatory bowel disease than the surrounding native population to Mexico City. And we know that the risk is higher in twins. And we see it in monozygotic twins, that there's almost a 67% concordance, especially for Crohn's disease in monozygotic twins. So what causes inflammatory bowel disease? That's the, I don't even say $1 million anymore with as much money as is put into figuring out treatments and figuring out causes. It's $1 billion question. And every time I go to a GI conference or an IBD conference, there's another, I feel like 10 or 15 genes that are talked about. And so there's 100 genes. There's this paper you'll see from 2012 in Nature described 110 genes that possibly could be associated with inflammatory bowel disease. The last conference I went to, over 200 genes now described that may have a role in the development of inflammatory bowel disease. And it's a nurture versus nature. Are there different triggers that may be environmental or dietary that are secondary or tertiary triggers for patients that have a genetic predisposition to develop this disease? Again, the worldwide incidence, it's seen, you see that sort of north-south split. And if you look at incidence rates of Crohn's disease and studies that are done across the world, you'll see that not only that we have a higher rate, like I showed here in the world map, but that rate over the last 4, 5, 6, 7 decades now continues to increase. And we've seen that across a lot of autoimmune diseases, right? We see it in a lot of autoimmune diseases. We see it in allergy and in other autoimmune diseases. And here we see it in both Crohn's disease and in ulcerative colitis, that the rates of the incidence rates of this disease over the last 7 decades continues to increase. So what causes inflammatory bowel disease? It's, again, like I said, the $1 billion question. Now, in my opinion, this Venn diagram really shows it nicely. It's somewhere with the intersection of gut microbes, the host microbiome, which you'll hear a lot of discussion about, the host immune response, environmental triggers, and genetic susceptibility. At the perfect intersection of those 4 entities are the patients that develop inflammatory bowel disease. So let's shift gears a little bit and talk a little bit about IBD therapeutics. And I didn't want to get this, I didn't want this to be real, immunologically heavy, but I did include some visual depictions of where these drugs are interacting with your patient's immune system. So classically, IBD therapeutics have been really centered around altering or modulating the immune response of the host. The biologic era, which is the advent of drugs like infliximab, adalimumab, those drugs that end with mab, monoclonal antibodies, in the biologic world in inflammatory bowel disease, has really been going on for the last 2 decades now. The first one, infliximab for inflammatory bowel disease, you can see was brought to market in the late 1990s and early 2000s. And since then, really the targeted therapy using biologics has really exploded. And I wanted to share what the landscape looks like in the next few slides so that you know, and you as you see these names come across your patient population, it'll help you understand maybe what you might be looking for in that patient, as well as what you need to do in terms of surveillance and maintenance. So the old state, I show this, I almost cringe showing this therapeutic pyramid because we've gotten away from this. This is the old therapeutic pyramid for inflammatory bowel disease, and it's really been sort of turned on its head or really just reinvented. So if for Crohn's disease, we don't use 5-ASAs. They have been shown not to be effective for Crohn's disease. They do have a role in ulcerative colitis. We try to avoid prednisone and steroid agents in pediatric patients with inflammatory bowel disease. So we've gotten away from using those. Our main therapeutic tools are the biologic agents and the immunomodulating agents. And even to a certain extent, that has been turned on its head because the immunomodulator agents are starting to be recognized as having long-term dermatological risk in the patient population as they become adults and the elderly. And so now we're really been focused on the use of biologic agents. We talk a lot about diet and we talk about surgery as options as well. So let's talk about how we try to figure that out. We were again involved in a study called RISK, which was funded by the Crohn's and Colitis Foundation. RISK enrolled a little over 900 newly diagnosed pediatric IBD patients across 26 centers in the United States. And that study followed the patients out 3 years and then was actually extended to 5 years. And the idea was to understand how patients evolved when physicians used whatever therapy they were comfortable or they thought was appropriate. And then we went back and said, okay, you have this group of patients that are becoming more severe, or these patients that are developing stricturing or fistulizing disease. And why are they doing that? How did you treat them? And so we're trying to go back now and risk stratify those patients at diagnosis and understand who did the best on what therapy. So we talked about immunomodulators. The ones you'll typically see your IBD patients on are azathioprine or 6-MP. Excuse me 1 second. I'm just gonna, sorry, it just keeps beeping. So our azathioprine, 6-MP, and Imuran, those are all the same medication. Imuran is the prodrug of azathioprine and 6-MP. Imuran is broken down to 6-MP in the human body. 6-MP is the metabolite that interferes or decreases white blood cell count, particularly making those patients lymphopenic. And that's a drug that's had been used for a long time in the treatment of Crohn's disease and ulcerative colitis. The risk now that I mentioned was the emerging long-term risk of dermatological cancers that's really made us move away from the use of azathioprine, 6-MP, and Imuran in our newly diagnosed Crohn's disease patients. And in my practice, I have not used that now as an induction therapy or maintenance therapy in newly diagnosed patients. We've really focused on using biologic agents because of their better safety profile as well as their better efficacy. Methotrexate is another immunomodulator that we commonly use, and we do still use methotrexate to a certain extent, but again, often used as a concomitant agent rather than a solo agent. So what are your biologic agents? Your biologic agents are your anti-TNFs. TNF stands for tumor necrosis factor. It's a potent modulator of inflammation in the human body. And the anti-TNFs target the TNF alpha, and essentially, like I explained sometimes to kids with a very blank look on their face, that the drug Pac-Man's up the antibodies, Pac-Man up the TNF. And usually the kids have no idea what I'm talking about. Hopefully some of you guys will remember what Pac-Man was. Prior to therapy, patients need to have screening for infectious etiologies, particularly tuberculosis. Here in the Valley and in areas where coccidio might be more prevalent, we screen all patients for cocci prior to starting them on the anti-TNFs. And we look at hepatitis B status prior to starting them on anti-TNFs. A lot of places are now adding varicella to that group. Varicella is a little bit harder because it's a live vaccine, and so it's hard to get that on board, but it's sometimes good to know what their status is. With hepatitis B, if their immunity has waned, we can of course booster them once they're on therapy because it's not a live vaccine. How do we follow therapy? We monitor labs, CBC, ALT, AST, CRP, SED rate, and we do a focused exam. I like to examine these kids every 3 months. We do a lymph node exam, cervical, axillary, inguinal, and then we do a hepatosplenic exam. The way that these risk, the adverse events like the lymphoma were recognized in patients on TNFs was blood work and lymph node or hepatosplenic exam. So that's very, very important to be done routinely on all of these patients. The major risk you'll see with the anti-TNFs is, like I said already, lymphoma. In fact, it comes with 2 black box warnings. The risk of lymphoma, particularly something called hepatosplenic T-cell lymphoma, which was a very serious lymphoma seen in a very rare group of patients that were on both azathioprine and anti-TNF medication, and it was uniformly fatal in that group of patients. It was also seen more commonly in young or adolescent males. So I'm particularly careful about exposing a young male to a drug like Imuran or azathioprine. The other black box warning for the anti-TNFs is the risk of infection. This is the list of the current biologics. Really only infliximab or Remicade or adalimumab or Humira are the only 2 that are approved in pediatric Crohn's disease and pediatric ulcerative colitis. Certolizumab is a pegylated anti-TNF that's approved in adults, and golimumab is another injectable anti-TNF that's also approved in adults. The unique place where some people have started trying to look at certolizumab because it's pegylated is in the young female that is interested in getting pregnant. Because of the pegylation, the anti-TNF drug does not cross the placenta, where in these other drugs, you can measure levels of anti-TNF in the newborn. That has not been noted to cause any birth defects, and it's still recommended that those patients, pregnant women, continue the medication throughout their pregnancy. We just the adults try to stage it to try to get it early in their 3rd trimester and then right after the baby is born. Drug monitoring has become a big part of our anti-TNF therapy, where we try to look at how the individual patient is metabolizing the drug and tolerating the drug. And you can see some of the reasons here where drug patients may have lower levels when we're monitoring these patients. Biosimilars are a new group of drugs that have come out that are essentially, they cannot be called generics. That's why this term biosimilar, it's a biologic product that's approved that has the same or highly similar to an already approved biologic agent. And I just listed this here for you guys to see in case you do come across some of these names. The 4-letter string at the end of the infliximab or adalimumab has no meaning. It's a random 4-letter string. It just indicates that it's a drug of a biosimilar group. Where does TNFs work without, again, causing any PTSD from immunology in medical school? I wanted to kind of show this depiction. And again, you guys can look at some of these slides. There's some new now alternate mechanism of action drugs called integrin blockers. And the new one is called Entyvio or vedolizumab. Vedolizumab is an alpha-4 beta-7 integrin blocker. And the way that it works and why it's thought to really be a unique drug in the treatment of inflammatory bowel disease is that it targets white blood cell recruitment receptors localized to the gut. And therefore, you're not having a systemic effect like you might have with an anti-TNF or the other immunomodulators or even steroids. You're blocking inflammation at the level of the gut. Now, vedolizumab is a drug that is sort of the brother to a drug that, again, maybe some of you guys are familiar with called Tysabri, that it originally was taken off the market because of the risk of PML associated with JC virus. It's subsequently been re-allowed into the market with very strict JC virus testing. But now, since we have vedolizumab for our IBD patients, that doesn't really play a role in inflammatory bowel disease. And you can see here, we're talking about the recruitment of white blood cells. And so this is inside of the blood vessel where it's trying to prevent the white blood cells coming into areas of inflammation. There's another new class of drugs called IL-12, IL-23 inhibitors that are now approved for adult Crohn's disease, as well as adult ulcerative colitis. We're looking here at PCH to be involved in the pediatric IBD trials. It's an IL-12, IL-23 inhibitor, initially approved for psoriasis, and I particularly found it valuable in patients that have extraintestinal manifestations like skin findings or joint findings. That's where we may use this medication if they've lost response to a TNF or if they've developed psoriasis from being on a TNF medication. And you can see again here, the IL-12, IL-23 prevents eventually the recruitment and the activation of that inflammation or inflammatory cascade. Lastly, there's a new drug on the adult side called a Janus kinase inhibitor, JAK inhibitor. It's called tofacitinib. It's an inhibitor of JAK1 and JAK3, and it's actually the first biologic agent that is an oral delivery. All of these medications I mentioned to you previously have to be either given IV or injection, and this is the first oral drug, and again, kind of shows you where it is here. So this is kind of an idea, again, to show you how much the growth of the inflammatory bowel disease therapeutics is. The future is bright, hopefully, and hopefully one day we actually get to a cure for this disease. I would be remiss to talk about therapy without talking about dietary therapy in inflammatory bowel disease. There's really been two therapies that have shown efficacy in inflammatory bowel disease. One called exclusive enteral nutrition, where patients get 12 weeks of 100% formula. They are not allowed to eat or drink anything else, 100% for 12 weeks, assess a response, and then go to a 70-30 split, 70% formula, 30% food, because that is the ongoing therapy. Other centers like CHOP, Children's Hospital of Philadelphia, have used this quite a bit and have gone as far as saying patients that respond to this therapy should get a G-tube placed, so they can stay on maintenance therapy, sustained therapy with the dietary regimen. The other therapy is something called specific carbohydrate diet. And for those of you that are interested in looking at this across autoimmune diseases, there's a great book by Dr. Susskind out of Seattle Children's called Nimble, and really talks about how to do this diet. And we've used it. Again, it's those patients that want to commit to a dietary therapy. Remember, remission for us now is defined not only as symptomatic resolution, but that idea that their mucosa has to be healed. And so goals for our treatment is to prove that they have endoscopic healing of their small bowel or large bowel. If you have endoscopic healing, you have mucosal healing of the gut. That is the greatest way to predict lack of long-term complications of this disease, including long-term risk of surgery, hospitalizations, and the long-term risk of colon cancer that can occur in these patients after 8 to 10 years of uncontrolled disease. Some of you may have seen when we followed these patients, we're using calprotectin or fecal calprotectin. It's a stool test that measures the degranulation of white blood cells in the stool. It's a non-invasive test, and we've gotten very comfortable using this as a way to monitor patients even for sort of indolent inflammation. What I like to do is I like to get a calprotectin at the time of a scope so I can correlate individually what that patient's calprotectin looks like. The last few slides, let's talk a little bit about health maintenance, especially as it applies to the pediatrician. Health maintenance is hugely important in any chronic disease and particularly important in this patient population. You'll see what we like to do here. We've created a multidisciplinary IBD clinic, and we hold that monthly. And in that clinic, we bring in patients that haven't been seen in greater than 200 days, but we also try to do a health maintenance visit. So it may be seen by one of my 16 partners, but once a year, they come to this clinic and get a health maintenance visit. And that's where we here focus on education and health maintenance and look at these ideas. We use a Crohn's and Colitis Foundation checklist, and I included it here for the visual depiction. And it's really important that we make sure that these patients have this global visit where we're making sure that they're getting all of this care. We talk about immunizations. I know immunizations hits a lot of our general practitioners. And so the best time to vaccinate, obviously, is before someone is started down their therapy. But that's often the worst time to be able to immunize because they don't have time to wait. So remember, the main thing for immunizations is that those patients on immunomodulator, immunosuppressive therapy, should not receive any live vaccines. The typical big offender tends to be the nasal flu. We ask everyone to get their flu shot, but get the injection. And I listed the other live vaccines that sometimes come up in our care. Lastly, you can't get away with a talk without just mentioning COVID. There's a great registry called Secure IBD. You can Google the website. It's an international registry where we're collecting any patients that were exposed to exposed to COVID, that were positive for COVID, that had IBD. So far, the early trends that have come out of that is to avoid steroids, to stay in remission, stay on your immunomodulating agents. So far, there's no data on the vaccine. In fact, IBD patients were specifically excluded from all of the all of the COVID trials. But our general recommendation, particularly for the mRNA vaccines, were that if you have the opportunity to get it, go ahead and get it. Final thoughts: suboptimal therapy is expensive. We want to treat our patients appropriately. Disease is aggressive and progressive. We know this from all of the natural history adult trials. We always weigh the risk and benefits of therapy and disease, but often patients focus on the risk of the therapies without understanding the true risk of this disease. There's a lot of at-risk groups. We're looking at that. Another trial I'm trying to get started here at Phoenix Children's is looking at our Asian American population and splitting South Asian and East Asian patients and looking how that different population is affected. Individualized therapy is really the new frontier, and it's an integral part of the predictive model that will be our continued advancement in the understanding of genetic and phenotypic data. What I always teach the learners is that stop thinking about escalating or moving therapy up. Think about the patient that's sitting in front of you and what is the most appropriate therapy for that child. I'm happy to answer any questions. These are my kiddos, 7 and 9. This was our when we came here for recruitment last year, and they got in to see our first spring training game. Hopefully we can get back to some sense of normalcy, and I look forward to meeting everybody in person, hopefully next year. Thank you, Micah, and I'm happy to answer any questions.
Thanks, Dr. Patel. We do have a few questions here, and we have a few minutes too, so if you have more questions, you're welcome to submit. Let me start with our first one, and you may have touched on this a little bit as the talk went on, but the question is, do the meds advertised on TV to reduce white blood cell count infiltration of the GI tract work?
Yeah. So I think probably what you're referring to is that vedolizumab or Entyvio. That's the commercial you've seen. Entyvio has been out advertising quite a bit because they're, and yes, it has shown to be effective in both. It actually has an FDA approval for both adult Crohn's disease and adult ulcerative colitis. When I reviewed the data, what I find is that it tends to be particularly effective in patients with large bowel disease. And so when I'm thinking about a patient that may have been on a TNF and now lost response or had an adverse reaction, and I'm thinking, what's going to be my choice, my next choice for their drug? And I need to think about their next or different MOA, a different mechanism of action. Often the way I split it in my mind is that if they have primarily large bowel disease, whether it is Crohn's colitis or ulcerative colitis, I really go down the route of thinking about vedolizumab or Entyvio. If they have more small bowel disease, or like I mentioned before, extraintestinal manifestations, particularly skin or joint, that's where I'm thinking more about Stelara or the IL-12 and 23. But the Entyvio data is very good. We're starting also hopefully be involved in the Entyvio pediatric trial. It doesn't have a pediatric indication yet. The original hesitancy with Entyvio was that it worked slowly. But there was a newer trial that actually compared Entyvio head-to-head with Humira, and it showed a more rapid response than was originally described in those defining trials. So yes, it is effective, and it currently does not have a black box warning. Okay, it doesn't have any black box warning. Now, I say that with a bit of caution. Remicade, when it first came to the market, also did not have a black box warning. The black box warning of lymphoma and infection were applied to the drug in post-marketing surveillance. So we are still equally vigilant in those kids on Entyvio, but it currently doesn't have a black box warning.
Great. Our next question is, could healthier lifestyles, for example, better diet, exercise, food supplements, taken earlier reduce triggers for IBD?
So yeah, it's a question. It's an idea that I believe in. I think what's happened especially in a lot of the developed countries, is that we've gotten to so much processed and artificial preservatives and processed foods that, it really speaks to, why doesn't this disease happen as much in India as it does here in this country? And now what you're seeing in India is, as you're having the urbanization of the population, that actually the rates are not starting to go up in the urbanized areas. So what does that say? That the patients that live a more rural or live off the land more seem to not have as much effect. Now, some people may argue, well, those people aren't brought to medical attention, or patients in India, the medical care in third world countries is behind our medical care, so they're not diagnosing IBD. That may be the case. But I think there is absolutely something to be said about the changes and the shift in our diet into more processed and more preserved. And that's where, as well as more of the concentrated sugars, our diet is so heavy in sugars, and that's where the specific carbohydrate diet really focuses, is to go back to more natural foods, but to really, its main focus is to remove the processed sugars, because the concept is that those sugars feed the wrong set of bacteria, and that sets off your microbiome, making you susceptible to developing inflammatory bowel disease. And if you shift that and get to a more protective microbiome, then maybe you can actually control your disease.
That's really interesting. And as you know, I do a lot of obesity and insulin resistance. And so I spend my days telling kids not to eat those foods, those simple sugars, because it stimulates your insulin and your insulin resistance. So it's fascinating that it has that effect as well. We have another question here. As a pediatrician, are there any specific concerns we should look for in a patient who comes in for cold symptoms or rash that is on a biologic?
Yeah, so that's a great question. I mean, I think that, when I tell patients that they're starting on biologic, I said, listen, maybe you would have, if Johnny got sick, you might have waited 3 to 5 days and seen if he got better before he seeked medical attention. Now that he's on a biologic, I want to think about seeking medical attention earlier, not because I think that all of a sudden Johnny is, at risk of having overwhelming infection, but when you're on an agent like a biologic, what I would like, and what I love for our pediatricians to do, and what I end up doing is having them seen early and evaluating common causes of being sick. common treatable causes of being sick. So, if they have an ear infection or strep throat or, flu season, whatever it is, if there is an opportunity to evaluate those early and treat those that are appropriate to treat early, I think that that helps those kids get better quicker, and also so that their infection doesn't linger at some point to actually trigger their disease to flare. Okay, so I don't think it's anything specific to look for. It is the treatable causes of infection that I'm asking you to look for and treat those early if possible.